Welcome to the Edelheit Experience, a compelling conversation about revolutionizing health and well-being, bringing you rich stories and lessons learned from leading corporate executives. Now, we'd like to introduce your host, Jonathan Edelheit.
Hello, everyone, and welcome to the Edelheit Experience. I have a really great guest with us today, Terri Dill, who is an expert in pharmaceutical and PBM contracts. And pharmaceutical costs, we know, are skyrocketing. 50% of healthcare spend is pharmacy spend. Almost 50% of that is specialty drugs. It's not getting any better. And Terri is going to help us shed some light on it as to what's going on now and what's coming in the future. Terri, thanks for joining us.
Thanks, Jonathan. So my name is Terri Dill. I am the principal at Skylight Arcs Consulting. We are a consulting company that focuses solely on the employer groups, pharmacy benefit manager contracts. Today's world around the PBM space, there's a lot of market consolidation that continues to go on, where you see larger, whether it's health plans or larger PBMs buying up the smaller PBMs to control the market share. But you're also starting to see a growth of smaller PBMs kind of pop up all over the industry with different kind of models that they're bringing to employer groups, whether they're transparent or pass-through models or traditional models, still in the terms of how they're adjudicating and passing back savings to employer groups. And so it's a good thing because it's creating competition with the Bucas of the world. So as many of you know, which are the CVS's, Optums, and Express Scripts. There's many mid-sized PBMs that are still out there. So lots of options for employer groups to choose from.
Now, is there a conflict of interest between the mergers between all these insurance companies and these pharmacy chains and PBMs? Is it, because the health insurance is profitable, or is it because a lot of the money's in the pharmaceutical side?
So a lot of the money has always been in the pharmaceutical side. And if you really look at, why these health plans are, and it's not just the health plans, some of the TPAs as well. So third-party administrators, are acquiring these PBMs is, yes, there is money in the pharmacy space. And the ways that the games are kind of played behind the scenes through whether it's your contract language or through rebates in your contracts with your manufacturers. So when you talk about why they're doing this is, yes, they're trying to bring all of that revenue kind of in-house and tucked under one umbrella. So you really can't peel back the layers of the onion to figure out where the stream or flow of revenue is going. But as we all know, that it's going to one entity. And that's really because they're controlling how these drugs are being dispensed, utilized, and the formularies and where the rebate dollars are being paid.
Now, you had mentioned, when you were giving your introduction about transparency and transparent PBMs. Just because the PBM calls themselves transparent, are they really transparent?
Transparent is definitely a buzzword. I always like to refer to it as translucent. Transparent to me, and just to explain to everybody else, is typically where a PBM is going to propose where they're giving the employer group a deal where they're passing through what the pharmacy who's dispensing the drug is charged. And they're associating what is referred to as an administration fee for that claim adjudication or that process. It does not mean that they're a transparent PBM, because again, there's still a lot of ways that a transparent PBM can play the games.
So I see the PBM space. There's a lot of the fox guarding the hen house when it comes to PBMs. And obviously, as you were saying, there's a lot of complexity, probably a total lack of true transparency. And a lot of self-funded companies, when they, looking at if 50% of the healthcare spend is the pharmacy side, do they bring in medical specialists or attorneys when they're negotiating these contracts?
Most employer groups, based on their size, do not have the resources nor the money to afford to bring in, the legal experts or the medical experts for that matter. So they're really relying on their consultant, who may have that arm of their consulting firm to bring those resources to the table. But ultimately, at the end of the day, my recommendation would always be is if they have access to a law firm who will help them oversee their pharmacy benefit at all as the plan fiduciaries, they really need to bring in at minimum the legal experts, especially if they're trying to change ways that they're procuring their pharmacy products. On the medical side, it's also kind of in the same sense, it would be a great resource to have at the table, but understandable, most of your employer groups, due to size and again, just revenue, don't have that as an option. So really it comes down to trust. Do you trust your consultant, and do you trust the PBM vendors or even the TPA partner for that matter, depending on who owns the PBM contract? That is the offer that's being brought to the table.
And when you say that, what's funny is kind of the hair on the back of my neck goes up because, going to law school and being an attorney and, saying trust the consultant, or, it's not a knock to consultants, or trust the PBM and the contractor that they're giving you. I feel like that's the last thing you should do. In my previous life, I ran a TPA, national TPA, and negotiated our PBM contracts. And coming from the attorney side, it was, extremely difficult to negotiate and get transparency and fight for it. I think it's pretty scary that companies are just putting their trust and not bringing on the right expertise. Is what big mistakes are employers making in their PBM agreements? What games are played? Where do they go wrong?
So most PBMs will share what I refer to as a condensed version of a pharmacy service agreement where the definitions are not disclosed to an employer group. Definitions are highly important and 100% will impact a group's financials. For example, how the PBM defines rebates will impact how the group is paid based upon the definition and their utilization. So if the rebate definition does not include certain language around, let's say, manufacturer admin fees, inflation price protection, or other just pharmaceutical manufacturer rebate revenue, the group then allows the PBM to retain any of the margin that the rebate aggregator is paying that PBM on behalf of that utilization. So it's really important that the employer groups do bring to the table whoever they can in terms of an expert when it comes to these PBM contracts, just because the PBMs have gotten really good at playing the games and the shuffle of where the money is being hidden.
So with that, it doesn't even matter if you have an attorney, you would need an attorney or an expert who specializes in this specific area, because if they're using condensed definitions, you need to have that expertise to pick up on that, right?
Yes, absolutely. In a condensed version, typically they're just going to disclose, here are the discounts, dispense fees, and here's a rebate dollar amount. That's usually what is in a condensed version. And you'll have some language around there, around terms, just your payment terms, what you can expect. Usually it's a 2-page document, where if you receive a true full pharmacy service agreement, it's typically 35 to 50 pages, because the first 10 pages could be just definitions alone.
So if you get a 2-page contract run, if you get a 30 to 50, 55 page, you're in a better position.
Yes, definitely.
Okay. So, and to me, hearing that term, condensed definitions in a contract, knowing, I work on contracts all the time, to me, that's so shady. I can't think of a better word than that, of that would make me want to dive in big or run for the hills. And it sounds like it just is, it's just a push to not be transparent and just to keep more money on the side of the PBM, shifting it away from the employer.
Absolutely. And I'll give you another example for just kind of how the employers or how the PBMs play the games with employers. So when you talk about, single source generics versus generics, it's another game that's played where the definition of generic drugs does not include single source generics. So many people will ask, what is a single source generic product? Well, that is where a manufacturer is the only manufacturer on the market that produces that particular generic product. So there's no competition generic wise for that product, where your other generics are referred to as multi-source, where there's other manufacturers who are producing that same generic product. And so the way the PBM will play the game is what, by not having the single source generic included in the generic definition, they will, what I refer to as, is rebucket that particular claim utilization into the brand products. Therefore, what it does when you allow the shift of that utilization to now adjudicate under the brand discount, it's at a lower rate for the employer group versus the generic dispense rate, which is typically significantly higher. And it also inflates the brand performance for the PBM. Therefore, when you get an end of year reconciliation, it's showing that the PBM has hit their brand performance number. Let's just say it's AWP minus 16, and they've shifted those single source generic products over to that bucket. Well, it increases obviously the claim volume, but it also increases how the brand discount performs. Where if you were to leave the single source generics into the generic bucket, they would adjudicate at a higher discounted rate for the employer group, therefore saving the plan money.
So could we just give like just a random dollar amount example? If we were saying like, let's say the drug costs $100, what that difference in savings could be from a dollar or percentage perspective?
So typically, if you're using $100, if it was, let's say AWP minus 15, the plan could pay potentially $85 versus if it's a generic discount, and let's say the generic discount's at a 81, 82, they could be paying $12.
It's a huge
difference. It's a significant difference, and based on where the claim is hitting and how it's being rectified. In the end, you're in reconciliations. It almost sounds buckets, I guess.
It almost sounds like, and I feel like we just started and just got into us, like, but it's like walking into a casino and, you going to play the slot machines, knowing the system is, it's like, what is it? 95, 97% of the time the house wins. That like it's built upon the same thing where everything is built. So the house wins.
Yep. It's rigged. It is 100% rigged. And you really have to have somebody who eats, lives, and breathes this industry to keep up with all the games, because I will tell you, the PBMs continue to change the games all the time.
So yeah, I'm sure, you get creative because you catch on, right? And then they've got to switch up the game based upon what people have caught on and kind of shuffle it. Like, what is it? The 3 cups with the P. I forget what that game is called. Do you know what I'm talking about?
Yes. I can't think of it either.
So a question I have is, what like in that single source generic, you gave a dollar amount, but like, what is the percentage? Like, are we saying it's like they could be getting an 80% savings, but instead they're getting like a 15% savings instead? Like and not just on the generics, but if we look at overall, what percentage of money are employers potentially just giving up and leaving on the table for the PBM that if they really dug into these contracts, they could be saving?
Oh, wow. Like you could be talking anywhere between 12 to 25% of overall spend.
But that's huge. If 50% of healthcare is the pharmacy side and everyone keeps getting rate increases, that like if they turn that around, that's like an actual big win for them.
It is. Absolutely. Absolutely. It's a big dollar amount.
Is there a percentage of like trend of the cost of what the pharmacy spend is going to be every single year?
So typically the way that it is viewed is, so right now with generics, generic trend is usually pretty flat, usually pretty low. Brand trend, if you remove specialty, is around 8%. That you can expect. But with specialty, when you kind of throw specialty into that, which is, we all know, is really a huge significant driver. And if you look at the drug pipeline, 50% of the drugs, if not more, that are in the pipeline are all considered specialty drugs. So that, which means they all come with high price tags. So with the trend of specialty, you're looking at about 12% trend.
That's pretty significant. So basically just what you're being overcharged plus the trend. I mean, that number is going to exponentially rise.
Correct. Yes. Which is why it is so important for employer groups when, you're doing your core, if you're allowed to get a quarterly review with your PBM vendor, to really walk through any reports that they're giving you and to look at what your trend is. Like, how is your membership, accessing their drug? Are they getting it filled at the lowest cost, potentially, whether that means at retail, or do you have some type of mail order incentive where you're getting better discounts on the back end for the mail order? Are they shifting in terms of specialty utilization from a lower cost specialty drug to a higher cost specialty drug? So you really have to look at what is driving your trend in terms of utilization patterns, just your drug mix overall, how and where your membership is getting their medication filled, and is it the most cost effective? Do you have copay incentives for your, preferred products versus non-preferred? And it's really key for the PBM vendors to have that as an option, especially if you've been with that vendor for quite some time, to sit down and go over that information with the employer group so that they can make educated decisions about how to move forward and ensure that they're really pulling all levers to control cost for moving forward.
Now, I'm sure a lot of employers are thinking, listen, I'm nailing it. I'm crushing it when it comes to discounts, when it comes to the PBM, agreeing to rebate minimums. What's really going on?
What I find often is that employer groups believe that they have these guarantees written in the agreement based on what they were either told, shown from the PBM, or again, trusting their, broker or consultant who they believe know and understand this industry. But what I have found is after reviewing many of these contracts, there are no minimum guarantees in place. And the agreement typically has offset language included in the agreement. So there's a lot of things that employers believe that they're doing right, but in fact, they're not. It's not that they're not doing it right, but again, they're just putting their trust into these vendors or partners that they have at the table, that they're doing the right thing and helping them manage their plan spend.
Since I'm getting kind of the vibe that the broker consultant is really who the employer is trusting on this. And I put myself back in the shoes of running a TPA, self-funding, dealing with the brokers, consultants, and being an attorney and knowing the expertise it requires in law school to read contracts, to spend years going over it. How can brokers be expected to be contractual experts on the PBM side? That seems like it's a real uphill, impossible battle, especially if the PBMs are constantly changing the game.
I would say that the majority of the larger brokerage firms now have what they refer to as a pharmacy benefit consulting team who really try to go out and live and breathe this industry. But your smaller, mid to smaller consulting companies or brokerage firms, I don't have that resource, which is why you see a lot of them go out and work with organizations like mine, where they can bring somebody to the table to help them really peel back the layers of the onion and identify what's in these contracts, what's not in the contracts, and how do we get the employers on track of moving forward. Now, what you may run into is that sometimes the brokers don't necessarily want those layers peeled back because they have, I wouldn't say it's a hidden agenda. It's not a hidden agenda, but there's hidden compensation that it was an area of revenue stream that they were gaining on behalf of that employer group's PBM contract.
I've heard of some brokers, consultants, and obviously this is not all of them, because one consultant actually shared this story with me of competing on a case and finding out that broker who had the broker record letter was making $1 per script. Is that something that is never heard of, or like you mentioned, are there different ways that some of these brokers or consultants are generating revenue on it?
So there are, and when you think of the grand scheme of thing or the big picture, so $1 per script, it's not really that much. It just depends on the size of the group, and because it's based on per claim, it really depends on the claim volume that's running through that plan, on what the broker's picking up in terms of compensation. But no matter what, whether there's hidden compensation or it's fully being disclosed, what's important is that the employer group understand that no matter how or the brokers, whether they're telling them or not telling them, no matter what, that money is coming out of their contract to pay for whether it's going to the broker or the consultant, whomever. So really it impacts the employer group in that sense. So anybody that comes to you and says, hey, we don't charge the employer for our services, meaning consultant for the, PBM consultant. That's not true. It always comes out of the employer group's margin, no matter what, no matter how it's written into the contract. But the other thing that I would like to say is that, there was some new legislation that has been passed recently. It's under the Consolidated Appropriations Act of 2021, which requires all vendors to disclose all compensation for services providers that are being paid on behalf of plan sponsors' business. So this means, and it is addressing all direct, which is typically the compensation that is disclosed on your 5500 forms, or now it includes indirect compensation. And these vendors must disclose to the plan fiduciary anything that's above $1,000 that's being paid to anyone. So it addresses to whom it's being paid to. They'd have to put in a description of the arrangement and the services that are being provided, and to the extent that the services have been received on the behalf of that individual or organization, I should say. And all of this must be done before December 27th of 2021. So they're supposed to do it prior to the renewal or extending any contract. And it really addresses a very broad swath of all of the types of vendors that really have been brought to the table on behalf of employer-sponsored benefits. And so it's really just another layer of true transparency, I believe, that they're trying to bring to the table to address those hidden compensations that are happening today.
Do you think that will really be enforced?
That's kind of the unknown. I think you're going to have vendors out there who potentially are not necessarily complying. But there are certain requirements that if a plan does request it of a vendor, they do have to supply that information to the plan fiduciary. So I think it's really around the employer groups becoming educated on what their rights are and what the request can be, and when they need to receive the request by, and what needs to be in that information provided back to them.
Now, is there a recommended term that an organization should have with their PBM, and what are they typically signing or think they're signing?
So most employer groups, I think, believe they're in a 1-year term, especially on the medical. If it's carved in with the medical carrier, they're like, if I'll talk to them, they'll say, I'm in a 1-year term with my PBM because it's tucked to my medical renewal. Well, what they find out is, when you get the actual agreement from the health plan is, oftentimes most health plans don't like doing a 1-year contract, because when they underwrite it, they want to underwrite it over a 3-year period. So if they're aggressive in their first year of underwriting, they have 2 additional years to make up for a loss. So what we have found is most of these employer groups who believe they're in a 1-year contract really are in a 3-year. And there's usually significant termination penalties associated if the group were to decide they did not want to stay with that PBM vendor after year 1. And it depends on if it's carved in with the health plan or the TPA, and what I refer to as a carve out where it's direct with the PBM vendor. What that penalty can look like. Oftentimes your health plan carriers, they'll associate it with what's referred to as a per employee per month penalty, or a percentage of the overall medical premium, where if it's direct with the with the PBM vendor, it's typically a percentage of what they will charge the PBM. The PBM will charge the employer for the early term.
Any examples you can give of what that could potentially look like?
It really depends. Are you talking like in terms of what the verbiage is, or what the penalty looks like?
The actual cost, like what that
So the actual cost. So if they're in a year 1 of a 3-year, and let's say it's $6 per EPM, and it really depends on your group size. So if you have a group, of 600 employees and it's $6, you have to pay that per month fee through the end of the contract. So if you've got 24 months left on your contract and it's $1,200 a month that you have to pay per month, it's a substantial amount of money that the group would be looking at to get out of that contract. So you would really have to evaluate where you want to go with the PBM partner and what your loss would be if you were to term early versus what your savings would be looking at your new vendor option. So really scorecarding it to say, is it really worth me losing, let's just say it's, $60,000. Is it really worth me losing $60,000 and walking away from all potential remaining rebates that are payable versus gaining, X in terms of savings if I move over to vendor, A.
And when you say it, so one of the penalties could be your owed rebates, and then the PBM just keeps it.
Yep, correct. That's
Okay.
typically the way it's written, in addition to the penalty, that they would retain all unpaid rebates. Yes.
Brings me back to my Las Vegas casino example, where you're down 10 grand. It's like 3 a.m. and you feel like maybe I should just keep, I'm going to win this hand if I could just, so it sounds like they keep you at the table. Now you're talking about the lengths of contracts is, I think this also comes into the concept of a market check. What is a market check? And, when was the last time, like when should employers be looking at this with their PBM contract?
Yes, absolutely. So typically with a 1-year agreement, there's usually no market check provision just because you're only in the contract for 1 year. But when referring to a true market check, it's really an evaluation of PBM services and scorecarding, multiple vendor options to produce a set percentage of savings that you're using certain agreed upon criteria. So most market check language that the current vendor has written into a contract, it will state that you have to use the same plan designs, you have to use a similar organization of size and SIC code. In addition, you have to use the same utilization management programs that are enacted. So let's say they have, prior authorizations, step therapy, quantity limits. We'll just use those 3. When you do the market check and compare them to other vendors, you have to scorecard them using all of that criteria. And then typically what they will do is they will say that when you scorecard me against these, let's say there's 5 other vendor options, you must produce at minimum 3% of savings, 5% of savings. They'll dictate that in the contract in order for the employer group to renegotiate the existing contract with the current PBM, the incumbent. So it's important that if an employer group is going to sign a 3-year contract with any PBM vendor, regardless if it's a carve-in or a carve-out, that they really have a market check provision in the agreement so that it gives them the option to go back, evaluate where the market is at in terms of pricing, which includes your discount, dispense fees, and rebates, to ensure that they're staying market relevant and competitive. And if you haven't done that in the last, 2 years, I would strongly recommend that you would complete either, if you have a market check in there, to do it, or to go out for RFP to make sure that you're doing just that.
So basically, it's, another one of the games of where it's, I'm just throwing out a price, but let's say a drug was $5,000, it could be $2,000 today. And if you don't have that market check in your agreement, the PBM gets to keep charging you the $5,000, and keeping $3,000 in profit.
Yes, correct. And the pricing, it just becomes stagnant or stale. Yes, 100%.
So, the word mafia popped up in my mind there. Not that I'm knocking the companies, but it seems like a very creative way. Every way they can put money in their pocket, they can. Now, you had mentioned before about quarterly audits. How do you make sure your PBM is meeting your contractual requirements? Like, how do you actually do audits? And tying that in there is like, what can you actually find? And the reason this is very important for me is when I ran the TPA, we did hospital bill auditing, and we would just find amazing, crazy stuff, like hospitals taking one surgery, breaking it out into 3 and billing it, putting stuff about medication to give the patient. We know they didn't, because the patient would be dead based upon their weight and the dosage of the medication. And being an attorney, I was the one that had to lead that. And when we would have the findings and even share it with the hospitals that blatantly were committing fraud wouldn't come back and say, I'm sorry, here's the revised bill. It's just shut up, F you, pay us. And you'd have to fight it. And so I'm curious as to how important are quarterly audits? What happens? And is it the same attitude that there is on the hospital side?
So they're not, so don't refer to them as quarterly audits. So it would be a quarterly review of how your plan is running. So completely different than an audit. So when you think about an audit would be completed at the end of the calendar year or the contract year or the plan year for that matter. So if let's say you're off plan year, calendar year, and you're a July 1 through a June 30, your audit could be completed after that, time frame. But to take a step back, if you think about when you meet with your PBM, typically the PBMs will meet with, employer groups based on size. The larger you are, the more often they want to meet with you. The smaller you are, that you're not meeting with them, every 6 months. But for a plan to be able to monitor how their plan is performing, you could do a quarterly review with your PBM to see how they're performing in comparison to the contract discounts and dispense fees. You won't be able to audit the performance until the contract is up for that calendar year, like I said, or the plan year. But what is important is that most PBMs will provide what is called a year-end reconciliation to show the employer group how the PBM performed in comparison to the contract terms. And oftentimes employer groups will just trust, again, that, hey, this looks great. I don't need to review it. They hit their metrics. We're good. Close the books. On we go. Well, what we find is that, unless you go back and really review it yourself or do a reconciliation on your own based on, like I said, the contract terms, then you have no way to compare how the plan really performed. So, that's where a PBM consultant really could come in and help an employer group determine whether or not that PBM really has met the metrics that are in the contract, because they would complete their own reconciliation to scorecard against what the PBM's providing. And if there's any discrepancies, this is where the consultants or the brokers, even for that matter, could go back and negotiate with the PBM to say, hey, here are where we found the discrepancies based on what's in the contract. You owe the employer group X if there is something to be paid. We do find quite often that there are monies that need to be paid that were not paid just because the group, again, accepted what was already provided to them. And once the group signs off on that, you can't go back and change it, which is unfortunate. But again, it's helping the PBM and it's putting the money back into the PBM's pocket because you're not questioning it.
Is there a percentage or an estimate or range of what that savings could be versus like the overall spend?
It really depends on the group size, and it all comes down to the contract. So if there's no guarantees in your contract, there's nothing you really can do. So I don't want to say that there's a percentage, like a market standard percentage out there. There's not. It all really comes down to what's in the contract.
Is there certain ones that you found a certain percentage? Because I'm just imagining, I'm a president, I'm a CEO of a company, and just saying, well, this could be de minimis. It could be 1/10 of 1% of what we spend. And so it's not a big deal to have audit language in my contract or try to see, if they're performing well and recover money.
Well, I will give you an example on a group that we recently did an audit on. And it was a, I won't call it, it's not a BUCA group, but it was about a 15,000 life group where when we completed the audit, and this was not typical, so I want to make that clear. But when we completed the audit, and keep in mind, this was strictly on the discounts and dispense fees. Rebates was not a part of this audit. So it was for a 3-year period. And again, when you talk about audit language, sometimes your PBMs are going to limit you to 1 plan year. This PBM this client just happened to have audit verbiage that allowed them to go back 2 prior plan periods in addition to the current plan period. So it encompassed a 3-year period. But the recoveries were like 1.8 million that were achieved. So again, it was a 15,000 life group. So to me, it was a pretty big group, but for the amount of money that was recovered for that time frame. So if you break that out for over a 3-year period, that's substantial for money that went back to the plan. So, when it comes to a true benefit audit on a PBM, just know that it's going to take at minimum 6 months to achieve. And again, it could be, you're right, where an employer group says, look, it's going to cost me more to do the audit than what I'm ever going to recoup. But when it comes down to your end of year reconciliations, I don't consider those audits. Those are where you can just stack up where and how your claim data performed against what the PBM is stating is in the contract and see where or if there's any potential discrepancy that you could go back then and work with your PBM if there is a shortfall somewhere. So I hope that answered your question. I don't have a percentage that I can give you just because, again, it kind of all depends on a lot of what.
With the example of the company that saved 1.8 million, which is quite substantial, was that, oops, it was an accident by the PBM, or just, it's just the games that are being played?
No, definitely not an accident, for sure. But what they had done is it all came down to the majority of the money that needed to be paid back was on the specialty, where they were stating there were exclusions when were not exclusions. There were no exclusions in the contract for specialty in terms of the discounts, but they had specialty guarantees that were not being met because of the way they were bucketing the claims into retail and mail. So when you put that data into the mail and retail buckets and you had specialty guarantees, you basically lost percentages in terms of your discount and how the claims were being adjudicated. So for example, if your retail discount was AWP minus 16, but your specialty discount for brand, let's say, was AWP minus 19, there's that 3% difference on all specialty claims of what the PBM was retaining.
So it's basically, it's the shell game, 3 cups, right? So it's just a shell game. It's, hey, let's just go move this over into another column, hope they don't come back and check or audit, and we'll just, this 1.8 million will be ours.
Continue on. Correct. Yeah. Absolutely. 100%. That is, so it was no accident by any means. In fact, they would have continued had our organization not completed the audit. Like nothing would have changed.
I kind of view that almost like I bring my car into the shop, and it's covered under the warranty, and they come back and say, your transmission broke on this 2-year-old car, but it's something else outside of the transmission, just so they're generating extra money. So my question is, if we wouldn't take it, from the dealer we bought our car from, or if our bank did this to us, this reminds me of I forget which bank it was, that scandal where they, opened up all these ATM accounts or other bank accounts for customers without them.
Wells Fargo.
Well, I'm sorry?
Wells Fargo.
Wells Fargo. Yes. So it was like, why is everyone, I feel like on the PBM side, like just letting it happen?
I think because they've gotten away with it for so long that it's just become such an important revenue stream for PBMs themselves. I mean, this is where I look at it as the pharmacy really produced and exploded in terms of how they could make substantial revenue. That this is why, and there was no governing body to oversee PBMs. In fact, there still really isn't. You're just now starting to see state legislation to go into place where there's actually oversight on PBMs, where today, if you look broadly nationally, there still really is no governing body federally that oversees PBMs.
It sounds like unless you have an attorney, a medical specialist, or a consultant like you're screwed if you're, trying to get in bed and feel like you're going to be able to be treated fairly with the PBM.
Yes, they're definitely, I think that's why you're starting to see more and more organizations bring in outside pharmacy consulting firms to really help them understand what they have in front of them and how they can continue to go forward to find the right partner to have at the table to really help guide them to make the right decisions and control their cost. Everybody's looking for a silver bullet when it comes to helping them control pharmacy spend. There is no silver bullet out there. So really, it all comes down to what can you do in terms of your contracts to help get you on the right path to really hold PBMs accountable and to bring back any type of revenue that is potentially owed to you as as you referred to, the checking account, because ultimately the employer groups are the ones writing and paying for all of this.
Now, if we look at it, we consider you the gatekeeper, right? Or the guardian of the gate. And when a company's looking at, okay, do I just suck up the cost of whatever the PBMs are stealing from me, or do I bring in that guardian at the gate to protect us? Like, what are the costs typically associated with bringing in someone like you to protect their interests?
So I would say most of your consulting, companies out there are charging either it's a PEPM or a, so per employer per month or a per member per month fee, or they could be charging just a flat total dollar amount. So think of it like a consulting fee where, based on your size, let's just say you're a, 5,000 life group, we're going to charge you 60,000 to help you oversee your entire PBM contract, monitor your PBM performance, and complete your year-end reconciliation. Most of them are pretty open to, negotiation, but I would say that really that's where you have to identify, again, because some of your pharmacy benefit consultants do have their own in-house deals that they push, meaning that they have preferred PBM vendors that they like to place their smaller employer groups with. So again, when you talk about the fox in the hen house, unfortunately, you have to be mindful of that as well, because some of your brokerage firms that have that consulting arm also kind of are in the weeds of getting compensation through their deals as well, which is why they're steering business to those certain PBMs. So unfortunately, again, there's a lot of money in pharmacy. So this is why I feel like you're starting to see more and more organizations, pop up to be able to get their hand in the pot. And it's, going back to where you really have to have and evaluate, who you want to have at the table, and are they the right partner for you, and are they trying to do the right thing, and bringing that resource to you. So I would say that, if they're a good organization, they're going to work with you on where their fees are going to be and what you can expect in terms of the scope of service and what they can provide for you.
Like other sectors, is there any kind of performance guarantee or ROI, like for every dollar you're putting towards the consultant who's kind of gatekeeping for you, this is what you're getting back? Is there any way to kind of measure that going into it, or able to see what the range is after the fact?
If you do, if an employer would do an RFP or even a renegotiation of the current contract, you could essentially see what that consultant has brought to the table based on what they've been able to negotiate. And you should be able to scorecard it through the end. And I won't say that it's necessarily through a performance metric or a guarantee, like if I don't produce X in savings, I'll pay you this. You don't see that on this, through the PBM consultants. But you should be able to see really what that consultant has brought to the table. And there should be consistent year over year savings that individual organization should be able to bring back to the employer group, regardless if they stay with the PBM vendor that they're with or they're moving to a different PBM. I wouldn't encourage, shopping your PBM all the time, because I'm not saying that all PBMs are bad. It's really just evaluating what you have. If you like your vendor, how do you strengthen your contract terms to produce the financial savings that you need in order to continue to have a profitable business of your own?
How do organizations know it's not just a zero-sum game? It's like whatever they pay to the consultant, that's what they get up in savings. And so they just ended up doing a lot of extra work.
Because, at the end of the day, everything should be disclosed. So you should be able to identify what your consultant is being paid. It should all be, above board and disclosed in the contract. And if you really are doing the right thing, meaning the consultant, you're going to produce savings year over year in terms of how you're negotiating the discounts, the dispense fees, the rebates. And, ultimately, if the PBMs continue changing the games on how they're structuring their terms and definitions, the consultant needs to stay abreast of all of that that's being played, which is the value that they're bringing to the table. In addition to just really keeping their eyes and ears open for what's going on in the market and bringing additional items to the table for the employer groups to consider. So it's not just evaluating and scorecarding based on what's in the contract. It's also, looking at what other items or vendors can you as a consultant bring to the table to ultimately help your you're bringing in terms of vendors to the table to help your employer group reduce their pharmacy spend.
So, okay, I think that's a great segue, because it's okay. We've gone through the I feel like the mafia games. Now, what are there cutting edge financial programs, clinical programs, and things that organizations can do to really bring down the cost or make sure There's this whole movement of getting the right care at the right time. Is the same thing true on the pharmacy side?
Absolutely. And there are some unique clinical programs that are out there that ultimately can help reduce waste. A lot of your PBMs, I always refer to as, the split, I always refer to it as the split fill program. So I'm sorry, I came from a pharmacy background. So that's why, and we had it, back in 2008, but a lot of the PBMs did not want to promote that. And so I think now you're starting to see more and more PBM vendors promote it on certain classes of drug just because they're oral. There's certain, products out there that you can't break, like your injectables, obviously. But there's, programs that are available that I don't think employer groups are aware of that they could potentially turn on that would help reduce some of those high cost drugs spend and ultimately waste. So it's just a matter of working with your PBM partner to identify what are my options, what is available to me, how does it impact my population, and how do we start to track and monitor to see that it's working and producing if there's savings associated.
So with that, I know some companies have, it's not a lot, but have rolled out like medical tourism into their pharmacy programs or specialty pharmacy. Do you see that as something viable for big cost savings? Where do you see that going? I know there's some employers in North Carolina, Texas, sending people to like the Cayman Islands or to Costa Rica for expensive drugs. Do you think that's going to continue?
I think employer groups are really strapped and trying to identify ways that they can continue paying at the rate that they're paying for these high cost drugs. So I do feel like employer groups are trying to evaluate any and every viable option that's available to them. And if it truly can meet the needs of the plan, but also the membership. So I always ask employer groups, it's really about your appetite on how you feel about change and really how you want to view your employees and their overall families. So I do see more and more employer groups, ultimately picking up international mail sourcing. And that's typically for your generic products or what I would refer to as your maintenance medications. So your insulins, your high blood pressure medications, a lot of oral. There's some specialty that's tucked into that, but not as much as I think employer groups would like to see. But there's reasons for that and why international pharmacies can't ship into the United States with these biologics. The other thing that I'm starting to see is really the unbundling of the services that employer groups are going after, meaning, they're looking at other vendors to control the prior authorization process where that was typically managed and held by the PBM. They're looking at outside, PBM non-specialty owned pharmacies and contracting direct with them for purchasing, and really still having it flow through the plan so that they're getting access to rebate dollars. But, it's just another way to address or identify, am I purchasing this drug at the lowest price possible? And then there's also, like you mentioned, the medical tourism. I really do feel like employer groups are struggling with the how fast paced the costs are rising in terms of pharmacy. And what are the solutions available to them that they can bring to the table that, is safe and they can get on board with, supporting?
Well, I feel like the world's a better place because of people like you in it who can help navigate this, because it sounds just like it's a hornet's nest and it's impossible for employers to do it on their own.
Unfortunately, it is, I think that's been the game that the PBMs have played. But for myself, this is what I thrive on. And I truly love working in this space. I love educating. And I am so excited when I get the chance to really work with employer groups who really want to understand, but also trust the fact that I am out there trying to advocate on their behalf, because I don't think it's a sustainable place where employer groups can continue to pay what they're paying. It's going to become a number one spend. It's no longer going to be the cost of, the employer group's goods or whatever their number one cost is. Employee health benefits are going to be number one cost to employer groups.
Well, I completely agree with you. And at the end of the day, as costs go up, those costs get shifted to the employees. And, this has an impact, I think, on employees. I think at the end of the day, the better benefits you have, the lower the costs. That's going to help with attraction, retention, all these things. And, this is the one area that I feel that employers can really tackle aggressively, but that most of them don't. They're tackling all these other areas in healthcare because the pharma side is less sexy. And that's why it was so important for you, for me to have you on the show to kind of share this.
Well, and I think the other piece of that too is just because it's so complex that, the broker space really didn't focus on it, just because if you think about it, 10, 12, 15 years ago, this pharmacy really wasn't that much of a cost driver. And now that, so much of the pipeline is really around specialty drugs, I think this is why there's been so much focused on it. And again, it all comes back to where the games have always been played, but now because there's so much dollars in it and employer groups are starting to ask the question, it is definitely a space where employer groups need to start on, peeling back the layers of the onion and identifying ways that they can start addressing the pharmacy cost.
They got to pull on some very big muck boots to wade through it, I think.
Yes, absolutely. Couldn't agree more.
So I feel like, if you're listening to this, you're a CFO, CEO, broker, director of benefits, you're like, okay, this is really bad. We're in bed with the mafia and they're doing all this stuff. At least I know they're doing this. In the other areas, we're still getting, what we should and maybe being treated fairly, or we're just making assumptions, right? Especially if we're getting a 2-page contract. So we're getting rebates on specialty drugs. So let me ask the question probably no employer asks, and most brokers and consultants don't ask, is, are organizations getting rebates on specialty drugs in the hospital or the doctor's office or the medical setting?
No, I will say that most employer groups are not getting paid the medical rebates that are owed to them. So there are a few TPAs I do know out there that are finally paying the medical rebates back to the employer groups. But typically the rebate amount that is, paid out based on specialty drugs that run through the medical benefits. So keep in mind that's your, hospital, you're administered in the doctor's office, your home health, all of that. It's usually equated to around $4 PM that could be potentially paid back. And it's based on, specific products that are rebatable and payable under the medical benefit. But definitely it's an area that I don't believe most consultants or employer groups for that matter are ensuring that they are either requesting it or getting it put into their medical agreement, which
so if I have 15,000 employees,
amount,
$4 per
but at the end of the
employee
day,
per month,
it could
I'm
add
basically
up.
spending $720,000 a year. In another example of the shell game where the PBM is kind of like, oh, you're not watching because this isn't mail order or pharmacy related. So I'm just going to keep this in my pocket.
Yep. And so this is where, the conversation comes back with the broker and consultant and, the employer group for that matter to say, look, it's okay if you want to leave these products under the medical benefit, but there's always the option to shift them to the pharmacy benefit where you could have the higher rebate yield. And sometimes that doesn't make sense. But this is an area that you need to address and go back with whoever your TPA is to say, look, those are dollars that are being paid on behalf of my claim utilization. So if I'm not going to get the full benefit of what you're getting paid, I at least need a portion of it. And so it opens the conversation, and it also comes back to the contract, really, again.
So
sure
basically, you fight to get money back in the medical setting, or try to put in processes or things in place so that this happens more on the retail or the mail order side, so you're getting the rebate. And when you were telling me that story, new analogy came in my mind, and it was, it's predator or prey. Right? It's, the PBM's a predator, the employer's the prey. And I was looking at this infographic of this chart in my mind of all these things they have to, like kind of a mind map of all the pitfalls that they have to avoid if they don't want to get eaten by the predator. Or they can determine, do I want to be prey, or do I need to do something so that, I'm the predator, and I'm not being taken advantage of.
Yeah, absolutely. Definitely. And, this is where employer groups need to be empowered with the knowledge to understand what they do and don't have. This is such an important topic.
And I just feel like, companies have just been raked over the coals and beaten up the last 2 years with the pandemic. And, they need more profitability. They need to look how to lower costs. And I just feel there's such a lack of education and transparency on it. And that's why I really wanted you to, be a part of the show, Terri, and share that knowledge.
Absolutely. And I appreciate it. And, this is an area that I love to go out and educate and really bring that knowledge to employer groups, because I do want to empower them to be able to be in control of how their pharmacy is being controlled. And
Thank
this
you.
is just, again, I
So that's
appreciate
it.
you bringing me on the show.